Welcome to the Medical Home webinar series. This is the concluding webinar in the series of 6 webinars on medical home for special healthcare needs. This topic, patient-centered communication, is applicable across the board, including the topics that were covered in previous 5 webinars. Today's webinar will be presented by Dr. Renee Turchi, the Medical Director and Principal Investigator of Pennsylvania Medical Home Program. Before we begin, a few announcements. This webinar series is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under the Genetic Services Project Grant to Health Research Inc., NIMAC. This activity has been approved for AMA-PRA Category 1 credits. There is reciprocity credit for allied health professionals, nurses, physician assistants, and nurse practitioners. The required CME accreditation is included in the slides and handouts. Instructions on how to obtain a CME certificate of credit is also included in the attached handout. These handouts can be accessed through the control panel on your screen. This live webinar will take approximately 1 hour and will be recorded. The recording will be available at a later date. As soon as the webinar concludes, you will be asked to complete an evaluation survey. Please take a few minutes to provide your feedback. Your input will help us in planning future activities. Participants claiming CME credits, please use how to obtain CME credit handout to complete your evaluation and claim your credit. All other participants, please complete the evaluation survey that follows after the webinar. There are no conflict of interest disclosure or off-label discussion to announce for this webinar. All participants are in listen-only mode. Please type in your questions if you have any questions or comments in the question box. We will try to address as many questions as possible. If we are not able to cover all questions, we will send up a summary of responses from the speaker. At this point, we would like to acknowledge our colleagues. We thank HRSA for their support. We thank all speakers and participants of the Medical Home webinar series for their contribution and participation in this webinar series. On that note, we are pleased to invite Dr. Renee Turchi, Medical Director and Principal Investigator of Pennsylvania Medical Home Program, to present this webinar on patient-centered communication. Dr. Turchi.
Thank you, Kunal. Thank you very much to NIMAC and all of my colleagues for inviting me to give this webinar today. It is my privilege to be talking about patient-centered communication, which really underscores our partnerships with patients, families, and communities. Next, please. So the objectives of our talk today are to illustrate examples of effective patient-provider communication and relate different clinical scenarios of patient-provider perspectives. Next. So in order to do that, I'm going to talk a bit about care coordination and care integration after I describe one family that really is going to be the underpinnings of our case discussion for most of the webinar. I'm also going to talk very briefly about some care integration models, specifically related to some of our experience in Pennsylvania, and highlight the role of team and key partners in patient communication, especially the roles of families, and thinking about how do I do this and some tools and lessons learned. Next. So many of you have heard about Don Berwick, who from the Institute of Healthcare Improvement talks about his triple aim, which really I think underscores the work that all of us do and keep so near and dear to our heart when we're working with patients and families. Excuse me. So what we're talking about is thinking about better health care for individuals and our individual patients and the individual families that we care for. And in doing that, we are then affecting, hopefully, the better health of the population. And so thinking about programs and organizations like NIMAC and Title V, looking at things through the lens of public health. And ultimately, the triple aim, sort of third arm of that, is lowering costs through improvement, as Don Berwick describes. Sometimes when we think about children with special health care needs, or some of the children that fall under the rubric of NIMAC and some of the children that are served, we know that their health care costs often can be high. So, for example, I have a patient with hemophilia who his factor just costs a certain amount of money that really is not expected to go down over time. So even if his care is coordinated and he has a medical home, that cost is pretty static. So it's important to think about sometimes knowing that cost, maybe it's more about appropriate cost. So that, for example, a patient like that may be kept out of the emergency department, and that his cost is focused more on the medication needed to improve his health care. Next, please. Recently, there's been, Dr. Berwick talked about adding a fourth arm that I think is worth mentioning for those of us that are engaged in this work. And people will often, you'll hear mention the quadruple aim. And that really refers to the idea that we should be thinking about those of us that are on the ground, the providers, and I don't just mean healthcare, I also mean our community partners. We should be ensuring that their satisfaction and their meaning in their work is also connected to all of the care that we're providing for our patients and families. We need to be sure that we're driving, in fact, the service that we provide, and that our teams are highly functional and satisfied as well. Next. So while this talk is not about the medical home, I'd be remiss if I didn't quote one of my dear friends and colleagues, Turchi. And I think that this quote is so germane, that when we think about the care that we're providing, the medical home is necessary but not sufficient. Next. And I think that this is very much highlighted by this one family's care map. So in the center here you'll see this is actually a care map that was drawn by the parent of G, who actually resides in Massachusetts. And this care map, as you'll see, as we slowly show the care map in pieces, you can see visually that these are all the various health-related supports that G's mom needs to interface with in order to maintain and improve his functioning. So you can see there are a variety of equipment and specialty providers. She also needs to interface with the school for G. So thinking about the transportation for school, the liaisons and directors and all the services he needs to be provided there, and the therapists that need to be interfacing with. And next, she has developmental assessment. So you can see that this is where care integration and communication comes into play, understanding what is it like for G's mom to ensure that the developmental assessments that she's also accessing are communicated between the school and the healthcare communities. Next. Also, in this case scenario, G's mom is also needing to get information, advocate, and be engaged in leadership. So she's involved in listservs seeking information. She's involved in perhaps her family-to-family health information system and various organizations that she's understanding, whether locally, regionally, and nationally, ways to connect. G's also a member of his community, so he may be involved in recreation, sports. He also needs to access insurance, so both public and private in some cases. Next. And also G's mom has legal and financial issues. So she needs to advocate for him and think about as he becomes an adult, what are the trust and estate issues that he needs? Does he need an educational consultant or an attorney? And most importantly, as you can see here, G's mom and their family need support. So who are their family and neighbors, their support groups, therapists? What's going on with his siblings and how to support them in his life. So I think that this care map really does underscore why we need to think about patient and family-centered communication. While the individual content of every one of those circles may not be relevant to every one of your patients, just at a glance realizing how much we need to be doing to help our families foster that communication and make it as seamless as possible. Next, please. So I think when we think about HRSA and a public health perspective and taking a step back from G for a moment to think about what happens at the government level. So when we think about Maternal Child Health Bureau at the systems model, and then kind of thinking about where G fits into that. So I like this slide that comes out from the Maternal Child Health Journal. Dr. Bethel talks about that, you know, we have children and families of children with special health care needs that hopefully have insurance to pay for the services that they need, that we saw in G's world. And this has to enable G and his family getting continuously screened for their special health care need, and also receiving services necessary for a successful transition to adult life, and that all of that is occurring under the guise of a comprehensive and coordinated medical home. And that community-based services, as you can see, are sort of surrounding all of that, and that they're provided with, you know, hopefully easily accessed and used, and that the most important thing, I think, is that families of children are partners in decision-making at all of these levels, and that decision-making influences at every mark in that service model. The communication and those partnerships are paramount. Next. So this slide I wanted to highlight because it really does underscore the issue of the life course perspective, and talks a little bit about, when you look here, the horizontal axis there is children as they age in life, so you can see from birth to age 16 to 17. And then we look at the vertical axis of the prevalence of children in the U.S. that the total number of children. And the different colored lines, as you see there, that we actually see that children with special health care needs actually have, as we look over time and we look at the life course perspective and we look at the prevalence of children with special health care needs, and then the prevalence of children with special health care needs with complex needs and those with emotional behavioral disorders, we can see that, I think that why I wanted to highlight this slide is that you look at the different ages that children with special health care needs find themselves, and look at what various issues may become more and more increasingly prevalent for children and families. And the other reason that I want to highlight the numbers of the slide is that it highlights the issue that we need to be continuously communicating and screening and working with our families, because if we look at those early years of life, while we see that we have children with special health care needs in between birth and the age of 1, it's 6.5% of having a special health care need. When we look across the life course, as children get older, that number goes anywhere from 9.3% to 26.2%. So it certainly grows with a variety of diagnoses. But it underscores the importance of communication and our need to be thinking about every encounter and every interface with children and families as an opportunity to connect with them and understand the issues that they're having. So how do we accomplish this? Next. This is where care coordination and integrated care, I think, is where our starting point is for some of this ultimate patient communication for families like G and the services needed over the course of his life. So think about care coordination as that set of activities, and if you will, the space between those visits, those providers, those hospital stays, thinking about G's care map, those places where mom is accessing therapists, accessing the school system, and G interfacing with his recreation. And integrated care really takes that one step deeper. It's that seamless provision of not just the healthcare services, but we need to think about, from the patient and family perspective, that continuum, right? So think about that life course perspective. So for G, from birth through adulthood, and thinking about that it doesn't matter where that provider sits. It doesn't matter if they're part of a hospital system, a children's hospital, they're community-based. It really has to be from the perspective of G's mom. If you think about that central circle where he sits, through her lens, integrated care needs to occur through all of those bubbles that I showed you at the inception of my talk. Next slide, please. Just wanted you to have in your handout the reference for the care coordination policy statement that came out in 2014 in Pediatrics. The article is a good one overviewing the role of patients and families in integrating care, and at the conclusion of the policy statement has lots of practical resources that many folks can use in the work that they do. Next, please. I wanted to take a minute to talk about Pennsylvania and some of the work that we've done, with the hopes that maybe some of what we've done could be replicated or be lessons learned for some of you on the webinar today. So in Pennsylvania, we've had a quality improvement initiative that has morphed into practice transformation since 2001. We've had funding from Title V and HRSA, and our work really sits in the PA chapter of the AAP office. And our goals have been to work with pediatric family medicine and internal medicine practices that incorporate family-centered care, promote care coordination and integration, work on data. We talk about finances and payment, and ultimately with the goal of high-quality, efficient healthcare delivery. Next, please. Just a brief map of Pennsylvania. I know that there's people from all over the U.S. on this call with different states. And, you know, Pennsylvania is a large commonwealth. The dots on this map just represent different practices that we've worked with as part of our medical homework. And we have clusters of practices in urban areas near Philadelphia and Pittsburgh, But we also have practices that we've worked with on that northern border. You can see some single pins there, which represent practices that are often the only pediatric provider in their county. So they are often practicing with limited access to hospital systems or specialty care, but in many ways represent the ultimate medical homes and really have to rely so much on quality patient communication. Next, please. So in order to accomplish some care integration, one of the things that we work on at the practice level is having practices really work on team development and also engaging parent partners, which I know we've talked about as part of some of our work in NIMAC, looking at team meetings that include community partners and certainly families, looking at managing populations and registry development, doing things like huddles in the practice to foster communication within the practice that ultimately fosters better communication with our families and patients. Care planning and mapping, as well as working with those community resources and providers. We also have developed implementation guides and worked on policy improvement. Next, please. So we've worked also to drill down, and for those of you that are thinking about working with partners or doing things regionally, think about employing the modality of learning collaboratives. I think that having things done regionally with within a 50, 100-mile radius of where you have a group of community partners, families, healthcare systems, or providers, we've found to be very effective when looking at rolling up our sleeves and working on care integration. So while we have biannual meetings all together in the Harrisburg, which is almost central in Pennsylvania, we have these local regional learning collaboratives where we come together twice a year. We work on regional issues that are driven by patient families and the practice and community partners. As I like to say, politics is local, so is providing care. We'll have our practice coordinators and parent advisors provide on-site and phone technical assistance, and we provide webinars and implementation guides to accomplish this. We also work with Dr. Rich Antonelli and Hannah Rosenberg at the National Center of Care Coordination, which is also a HRSA-funded entity. Next, please. So I wanted to just highlight the importance of team building. When we think about patient and provider communication, we need to have a healthy team that can communicate at every level. It's so important for us to recognize that communication is not just a communication that occurs within me as Dr. Turchi in the exam room with my patient and family. While absolutely that communication and optimal communication is paramount, it's important that communication is effective with every team member in my practice as they interface with all of our families. So part of that is doing things like what we call reciprocal and honest communication. So you need to have a healthy team internally. So your team has to be able to also have what I like to call appreciative inquiry. And this is the idea that you're hearing from all of your team members, hearing about what's working and not working, and allowing everyone to have a forum and a place to sort of talk about from their perspective, from where they sit. Maybe I'm at the front desk. Maybe I'm at the person taking the intakes and the appointments. When we think about access and families' ability to communicate for their needs, they often are not getting their healthcare provider, a physician or nurse practitioner or PA on the phone. So it's so important that those team members have a voice and can help you talk about what's working. Also thinking about the concept of relational care coordination. This concept actually comes out of the business sector and is described in our care coordination policy statement in further detail if you're interested. But really this idea, which I think is a good one, I think is something that probably folks like Toyota and IBM use, although I don't know because I had never worked for them. But when you read some of the information around this, and when I heard Dr. Carl Cooley talk about this, it made sense to me because it really focuses on the quality of communication and relationships. So it looks at, within a team and very practically, within your office, are people working to the top of their license? Do you have nurses spending half their day faxing when you might have an administrative assistant that probably can do it more efficiently so that nurse can then have more timely access to returning phone calls? And really looking at integrating tasks. So maybe you're cross-training folks so that when someone is out, things don't come to a grinding halt. Looking at things like workflows and that, you really can understand from everyone's perspective and not manage things from top down, but maybe bottom up and kind of meet in the middle. Next, please. So huddles are something I mentioned earlier. I think also in terms of the practice level, these are things that are really important. We need to think about the timing of huddles. We often do them in my own practice before the clinic starts. You've run through the day. It's kind of like a playbook. It gets everyone jazzed up. Sometimes there's things that may not be an electronic health record someone may have in their head, or maybe it's not adequately described. I think it's important to have everyone on the team that's going to be managing or touching your families that day be a part of those huddles, so you can talk honestly and openly about what to expect. Maybe there's a cancellation. How can this day be managed most efficiently? Also thinking about the use of your electronic health record. I know that for many of us, electronic health records can sometimes make things a little slower. Sometimes our electronic health records don't have everything we want in them. But when you really think about communication, I know for me that one of the things I love about my health record is that I can see the specialist notes. I don't have to dig through paper, that I can task people, that now with the advent of something like a patient portal, which I'll talk about, those are things that you can really then push information out, allows us to leverage the use of technology. And the nice thing is that they're living and breathing. And so while sometimes I do feel like it takes an act of Congress to make changes to the EHR, at least you know you don't have a product that is not going to get updated, and it doesn't necessarily mean that you don't have the opportunity to perhaps make changes. Thinking about huddles and pre-visit contact, I think that one of the things that some practices and folks have found really helpful that I think also foster communication is having a pre-visit contact with families. So this may be something that could be done at the time of an appointment confirmation, where you might ask the person that's confirming the appointment, what are some of your top concerns for your visit with Dr. Smith tomorrow? What has happened since your last visit? Has your child, been to the hospital? Have they gone to the ED? Have there been changes in their health care status? This could also be done electronically. If you have families that can use patient portals, or you can send emails out, families can fill these things out in advance, so that this also can foster efficiency. Then the provider or anyone on the team can look and say, wow, Johnny had a major life event, his family got divorced, or wow, Johnny was hospitalized. I really need to make sure I get that note from neurology or the discharge summary. I didn't realize he was hospitalized. That allows someone to be working on that while you're seeing a patient. So when you walk into Johnny's room, your communication with that family can be optimized. Also thinking about things like pre-orders and appointment setting and screening. When you can get things done in advance of the appointment, it allows your time to be spent face-to-face with families, really doing what we want to do, which is be hearing directly from them, rather than having to wait for them to fill out forms in the room or in our waiting room or in the exam room. Next, please. I just like this slide. I thought it was a little humorous, where the toothbrush is just saying, sometimes I feel like I have the worst job in the world, and the toilet paper says, yeah, right. And obviously I like a little bit of humor because that's just my personality, but more importantly, I think the point of this cartoon is really to highlight that sometimes teams aren't always in Oz, right? So sometimes we all have to recognize that shared responsibility and understanding that we're not always going to love what we're doing in the moment. But if it's for the good of the team and our communication is optimal, that will ultimately restore or maintain a healthy team. Next, please. So care planning is really where I wanted to go next. Next, please. So care plans. I am a staunch believer in care plans. I really believe that care plans foster optimal patient-provider communication. And while my care plan may look very different in my system, in my state, with my EHR than Dr. Ostrander, who's in New York and is a family physician with a different EHR, the point is not that ours look a little different, but the point is that we're both developing them for the same common goal, which is high-quality care and optimal communication. So when you're sitting there, who should be having a care plan? Really, we want to think about this for patients who have multiple diagnoses, multiple medications, perhaps patients that have shift or home nursing. Maybe a parent might request that they need a care plan for their child. Also, when you have many healthcare providers managing a child, it can be beneficial. Anyone with a complicated medical history, many specialty appointments, and also if you've had a family that struggled being compliant with a regimen, sometimes a care plan can be their beacon. Next, please. So when thinking about really launching into care planning, and I'm very practical, so how would you do this? You want to identify who would benefit. You want to think about the value of that care plan for your population, for your families. And so paramount, I should have bolded that third bullet, is that you want to assess the use and patient and family their goals and set goals with them, not for them. So remember that. Set goals with them, not for them. We should always have them engaged in the discussion as we talk about what we want to do. I always think one of the most important questions, no matter what age of a child I'm seeing, at some point in different visits, it's what are your goals for your child? It really helps us understand where families are and where they want to go in that moment. Also, care planning can link partners, both the community partners and the specialists. Again, I urge you to think about care plans beyond just the medical realm. Think about the educational system. Think about developing that care plan. You establish the plan, again, including goals in there. You want to make sure it's accessible, right? So if you have this beautiful care plan and nobody can see it except for you, it's not really going to help much. So think about it as being living and breathing. It needs to be updated. It needs to be monitored. It needs to be available. I love the idea of the patient portal. If you have a patient portal, which many of us have even in the adult world, families can get an app. If they're sitting in school, they're sitting at work, they can go online, they can see that care plan. If you made an update to it, they have the most latest and greatest living and breathing document. Think about making sure that your care plan is life course and population health friendly. So does it address things like transition to adult-oriented systems? Are you thinking about vocation? Also think about incorporating clinical practice guidelines. And if you have an EHR, sometimes they have visit summaries or care plans that are already available. I know our EHR came with the AAP Emergency Health Information Form that was already there, and then we tailored a different care plan based on that. But there's lots of samples out there, even on the National Center for Medical Home Implementation website. Next, please. I wanted you to have, just as on your slide, some ideas of things that you could include on the care plan, and you can see there and have those that you really want to be thinking about medical issues as well as therapies, phone numbers, providers, and I just want to highlight particularly the need to make sure you think about equipment that the child may use in case you're ever not there and the child needs a refill so that someone knows what size G-tube a child might have if they need to get it replaced in the emergency department, or perhaps mom or dad's not there and the G-tube is missing, something like that, as well as also thinking about the child's needs and strengths. We always want to be thinking about things that a child can do, not all the things that they can't, in the words of a parent. Next, please. Again, families should be involved in these care plans and care planning. They should get a copy at the end of the visit. As I mentioned earlier, hopefully they can access it via your patient portal if you have one. We sometimes practices have found it useful to actually print out a version, have the families review it before they leave the office. They could perhaps sign it. We did find that in some practices we're actually creating care plans and weren't actually giving copies to families. The other thing that I would urge you to think about is if you're working with youth, to think about employing self-assessments. There's several validated self-assessments, like the On Track tool that you could be using, that some of those self-assessment results or portions of them can be included in the care plan. Next. So a benefit of a care plan is that it empowers a family and can, again, as I think I've said many times here, can improve that communication, can provide information if that family's not present, the family may not have to repeat the history, and it allows salient, rapid information exchange, especially during an emergency, like at school or in an emergency department, or let's say the community or recreational event, if a caregiver that knows the child well isn't present. Next, please. As you're thinking about some of these patient communication goals, think about making things realistic. I like to chunk things out and think about what can I do in my office next Monday, next month, next March, or next year. So think about, biting your elephant, as I like to say it, one at a time, one bite at a time, and that, you really take baby steps and set short-term and long-term goals and make them achievable. Next, please. One thing that we did in Pennsylvania that I thought might be relevant and interesting to this group is that we did do a study a couple of years ago with a cohort of about 23 practices that really made me think a lot about patient communication and this talk. So we had the practices and their teams track what they were doing with respect to care coordination, how much time they spent on it, and what were the activities. And you can see here that all of the things that they did, in my mind, foster patient communication. So face-to-face, email, they had conferences, they were working on these care plans, they were working on appointment scheduling, they had telephone contact and chart review and did forms. And you can see that the encounters range anywhere from 7 to 23 minutes, so not time prohibitive. And there were over 80,000 encounters that were tracked in this particular study. Next slide. We then also took a cohort of children in the study that had asthma and looked at the association of the care coordination and the time involved in care coordination and how it favored on emergency department utilization. So we found that over time, the longer that any child with asthma was involved in care integration, they had a statistically significant decrease in ED visits, which is really what this slide shows. And we then broke down the children with asthma, as you can see, from severities 1 to 4, with 4 being the most severe. And we found that within each severity, it was still remains statistically significant, but the most dramatic slope in this survival analysis done by people far smarter than me was with children with the most mild asthma, severity of 1. So while children with the most severe asthma, severity of 4, were still favorably impacted by care coordination, the biggest bang for the buck was felt with those with mild asthma. So it underscores to me that we should be coordinating and integrating care and communicating for all patients, but that we certainly have missed opportunities if we're thinking that some children with mild illnesses don't need care integration. Often those are the children that we can impact the most. Next slide, please. So we know that families are key partners, and that's a key take-home point from my talk today. Next slide. And then thinking about family-centered care, I think that hopefully most of the folks on this call recognize that in order to achieve optimal patient communication, we need to be employing all of the tenets of family-centered care. So part of that is listening carefully at every encounter, spending time with the patient and the family, being sensitive to their needs and values, providing needed information, and making the parent and the child and the youth feel like a partner. And as I like to say to all of my patients and students, that we have to remember that parents and families truly are the expert in their child's care. They really know their child's best, and it should get our attention when they say that something isn't right. Next, please. So family engagement tools and activities. I wanted to provide you with some ideas and examples of things that folks could do both in and out of offices to think about ways to provide family engagement and communication. So thinking about resource bulletin boards that could be manned by community partners, parents, having suggestion boxes to get feedback in real time and anonymously from patients and families, having resource fairs, fun nights where families are then engaged and come together, having parent advocates on site and community liaisons to be there with families, having parent partner groups where parents can come in and have support groups or talk together amongst themselves. Thinking about parents as medical home team members and having them part of grand rounds if that's something that your organization or hospital provides. Having them be part of care plan development. We've also found that for some agencies and practices, having contracts for parent partners, so there's mutual understanding about the expectations, can be beneficial. Also having advertisements and newsletters can be useful, as well as family faculty and advisory councils, where families are key members of those. So fostering family-centered care and care integration. We've had examples where families have really driven policy change. Also thinking about having training for your family leaders and having them represented on all committees and work groups. Also thinking about hiring and paying your parent advisors for their expertise. Having them engaged in social media. And I already mentioned family faculty and advisory councils. And just really having them be part of and driving your community partnerships and events. Next, please. So parent partners really need to be thought of as part of your practice team. They can be part of a support group. Maybe there's a QI project. Maybe they can be a mentor to a group of parents outside of your agency, or maybe they can be part of an external advisory council. Next, please. So thinking about social networking, which I mentioned, we have parent advisors in Pennsylvania that man our Especially for Parents Facebook page. I think that electronic health records and patient portals are really critical. If you think about a patient portal, we really need to be getting feedback from the end user, who in our case is our parents and our families. So they need to be giving us feedback, and they need to be able to access those patient portals. And also families should be able to, yep, there's the Facebook page, thank you. You can go on. And next slide after that. So this is just a quick segue slide of olive oil is made from olives. What is baby oil made of? Oh, my God. So I just thought that was pretty cute, especially because I'm Italian. So I think the most important thing to remember is that as we think about optimal communication, we need to ask the questions to truly understand where our patients and families are sitting. So in line with that, we need to be thinking about how do we ask those questions, what's the best format. Next, please. So in Pennsylvania, we developed our own family survey that was stemmed off a lot of questions from the National Survey of Children with Special Health Care Needs. We got survey results from 156 practices in Pennsylvania and had over 3,000 responses, and you can see the domains there on your slide, many of which center around medical home and access to care and care coordination. We thought it was particularly important for us to understand the family experience from the parent perspective and have it be looked at the practice level. What we often will then do is provide them with responses based on their own practice, but showing them how they benchmark to the larger cohort, which just sort of is not meant to be punitive. Many times the responses are favorable, but it helps look at areas to work on or to think about for, as I said, establishing those goals. Next, please. So this is just an example of a particular communication question that I think is of relevance to discuss here today. So we asked families, how do they rate communication between their child's PCP and their specialist? And you can see that while the majority of families said that communication was excellent or good, there was a cohort of just about 18% of parents who said they weren't sure what that communication quality was like. And that to me kind of made me kind of rub my head and say, because if we're actually communicating with specialists and families don't ultimately know that we've had some discussion that may impact their child's care, we have to close that loop. So again, thinking about how we communicate with families about how we're communicating is part of the communication. Next, please. I wanted to provide you with a couple other resources to think about if you're really thinking about trying to understand that perspective with a formal validated instrument, because I know many of us really aren't in a position to be developing surveys. And you certainly want to be using things that are validated so that you know the information you're collecting is, it has data integrity and fidelity. So the folks, Rich Antonelli and his team, whose contact information are on your slide, up at Boston Children's, they developed something called the Pediatric Integrated Care Survey, the PICS tool, that was funded by the Packard Foundation. And it's a validated experiential instrument that really looks at very specifically care integration. It's a really nice instrument, and it's brief enough to get done, but any of you that are interested in looking at, from the family perspective, what the quality of care integration is, this is a great tool to use. Next, please. I also know that many of us may be in health systems, so remembering that the Consumer Assessment of Health Plan Survey, the CAP survey that is available on AHRQ's website, is in use by some insurance plans. It's also recognized by certification entities like NCQA, so there is a pediatric version. So again, if you're looking for a tool to use and pick up, I would encourage you to take a look at some of the ones that I mentioned. Next, please. I talked a bit about community partnerships in my talk so far, but I wanted to underscore the importance of those. I mentioned some of these settings, but I want to call them out for a minute. So the education sector is instrumental. Thinking back to G and how school really represented an entire left upper corner of his family's and his experience. Also, home nursing agencies. It's so important to have a workflow, thinking about how those nursing orders come through to the practice level, how those nursing orders are reconciled, how they're communicated back with families so that accurate, timely information is shared. Child care settings, also equipment companies, really thinking about them as community partners. The reason I have a picture of Elmo there with a feeding pump is actually a true story. Probably about a month ago in my office, we had a patient of ours who was visiting Sesame Place on one of their days that they had that was disability friendly for children with special health care needs. They really do a nice job a couple times a year of opening a park for kids that have autism, where they turn down like the lights and the sensory issues, and they do another day for children with physical disabilities. So he and his family were there, and his mom left his feeding pump on the teacup ride and didn't realize till she got home. So the next day she called, and they didn't have it, and she went back to the park, and they didn't have it. So clearly it was we're not sure what happened to it. We're thinking that maybe Elmo has it, so that's why I show his picture there. So we're not really sure what happened to it, but the bottom line is we couldn't get another one approved by the insurance companies. So we actually called one of our medical equipment companies who's local and got one out to the family for us. Pro bono. And I think that, hopefully those kinds of things don't happen too often, but the reality is things just happen. Kids in life is life. So this little guy, his mom wasn't in a position to continue to bolus feed him with syringes. And so having community partners that are local and are invested in the population you serve is paramount. And that communication is integral in making sure children get what they need. Thinking about communicating with your local and state health departments, many times there's initiatives that they're working on that can be partnered across agencies, and you can work together on common goals. Title V, your Title V agencies are setting priorities every year, and they want to work with their constituents and their community partners. So be sure to always think about them as your community partners. Family and patient advocacy groups are key. There's family-to-family health information centers. There's the Family Voices National Group, all doing wonderful things, have lots of conferences. There's also local parent groups that many are independent in various states and territories, parent to parent. So think about those folks. Also, several folks, like I know in New York, there's the Harlem Children's Zone. I think Connecticut, they have Help Me Grow. In Pennsylvania, we have a medical legal partnership in Philadelphia. We partner with the Disability Law Project, and we have lawyers that are accessible to our families to help them with things like SSI, family court, domestic violence, things like that. And so those community partnerships are so integral to communication and helping our families get what they need. Next, please. So transitions of care. I wanted to spend a minute on transitions of care, and there's two sort of aspects of transition that I want to address. Next, please. So this slide, the butterfly saying that's an old photo, and the police officer sees him as a caterpillar. So the first part of transition that I just wanted to highlight, next please, is transition to adult-oriented systems. And I just wanted to highlight our GOT transition folks, the National Center with Patience White and Peggy McManus, also a HRSA-funded National Center, have great resources on their website. And I know that they've done different webinars in the past, but thinking about, there's evidence-based, they've got amazing tools up there. I encourage you to think about, the 6 core elements of healthcare transition. And when you think about patient communication, there's lots of tools they have available where you can be communicating with both adult pediatric providers, with your families, with your youth. They have some of those readiness assessments that I mentioned. Also, Dr. White has been developing some condition-specific examples to help adult providers. Even in the family medicine sector, where they acknowledge that while some youth aren't necessarily going to be switching healthcare providers, there's still a developmental aspect of transition that occurs. And very recently I heard Dr. Luther Robinson say a quote that I think is so important. And what he said is that children don't outgrow their condition. They outgrow their pediatricians. And I think that that's so important when we think about transition, right? Because as emotional as transition is for all of us, and I throw myself on that ring, we need to think about how tough it is, but how optimal communication is really going to be the key to sort of traversing and having an effective journey across these various healthcare transitions. Next, please. The other transition that I wanted to just highlight was the pediatric transition or adult transition from inpatient to outpatient. And I just wanted to highlight, that there was a brief study and that we did that just at St. Christopher's Hospital for Children, actually, a colleague of mine, David Cooperberg, a hospitalist, really spearheaded this, looking at optimal communication from the inpatient to outpatient sector, and really found that having a nurse do some pre-discharge teach back to families before they left and going through a checklist made a huge difference before a child was discharged. And then, the ideal was to have a perfect handoff. And one of the things that really made the linchpin was having a post-discharge phone call occur on the medical home primary care sector site, where that post-discharge phone call included teach-backing, making sure that the family got the needed medications, that the family understood the needed equipment, that they had a follow-up appointment set up with either their PCP or their specialist. And in the study, we found that over time, those post-discharge calls actually reduced 15-day readmissions, and actually those post-discharge calls, you can go to the next slide, really also helped in correction of misinformation. And an important thing, and it gets back to my sort of timeline that I mentioned earlier for you guys, none of the perfect handoff or teach back or phone calls occurred during the first 6 months. So remembering is that you're starting to think about things that you want to do, that you want to have realistic goals for this communication, and that it sometimes is going to take time to achieve the results that you want. I wanted to provide you just a slide that Peggy McManus really spearheaded a nice article that came out in AAP News. For those of you that are interested in payment around transition, there's some good codes in there. So if you need that as a resource, you have it next. I also wanted to highlight another resource for those of you that are interested in medical home. It includes some modules around medical home for residency education. They're case-based modules that came out of some work that was done through National AAP, who launched a medical home resident education initiative work group, and really brought together a group of folks that are multidisciplinary to provide direction and develop some tools regarding the core tenets of medical home, and did a needs assessment and developed a comprehensive curriculum. Next, please. And you can see there we had some modules that the team worked on, and very many of those, they're all case-based scenarios, and you can see sort of how it's laid out with a pre- and post-test. But I like them because they're case-based scenarios, and they really do address communication across the board. Next, please. They're freely available, so you can go to the website there if this is something that you think you might be interested in. You can always contact Dana Bright as well, because she also can be a great resource for you. Next, please. So I wanted to kind of wrap up here and allow some time for some questions and just kind of highlight some key take-home points. Next, please. So I think we talked a little bit about, the role of medical home being necessary but not sufficient, that care coordination and care integrations are so paramount for effective provider communication. And I encourage you to hold G's care map in your head when you're sort of thinking about how important it is to work with and across agencies and systems. The role of families and community partners cannot be overstated. You need to be talking to the folks, to walk in their shoes, to really understand where folks are and hear from them in a not token way. So think about suggestion boxes, formal surveys, having outside entities help you understand their experience. That's the only way we get better is with constructive feedback. Always remember your other partners. Title V, in our case, our local AAP chapter is a huge partner. We also have a wonderful Medicaid medical director who supports us, your parent advocates, your payers and insurance companies. Think about collaborating with the national centers. I mentioned a few of them today. Certainly got transition. Rich Antonelli and his group at the Care Coordination Technical Assistance Center. Always remember to track your data. I tried not to overload you with too much data, but wanted you to have a flavor of the role of data and how it can be your beacon to show improvement, show you where to go next, and often can help you in periods of negotiation or to say, hey, we got this, now let's move on to our next project. And again, remember transition. Transition across systems, so from inpatient to outpatient, also to adult-oriented systems, not just from pediatric to adult provider, but within providers in family medicine, as well as thinking about transition in the education system, in the insurance system, in the school to college or day programs, as well as Office of Vocational Rehab. Those all are examples of where optimal patient and youth and family communication is paramount. Next, please. So I don't know how many of you know, but the most interesting man in the world, our Dos Equis guy, he's going to be retiring. So in his honor, I wanted to show his cartoon because you're not going to get to see him much more. So what he recently said to me was, I don't always go to my medical home, but when I do, things are family-centered, stay coordinated, my friends. So cheers to the Dos Equis guy. Next slide, please. This is the medical home website. We have a lot of the resources I referred to on our PA Medical Home website. Feel free to visit us. Next slide, I had some resources and references that come from a lot of the work that my friend Rich Antonelli has done. Next slide has my contact information. I'm happy to take any questions, and I'll turn it back over to you, Kunal.
Thank you, Dr. Turchi. That was an excellent presentation, and I think it covered key points from all previous webinars, including practice team huddles by Dr. Ostrander, Mitzi's, and Nicole's behavioral health, QI webinar by Ruth, cultural humility by Dr. Badartha, Maria Isabel and Helen, and resources by Shama and Malia. So thank you so much for this presentation. We do have a few questions and comments. A participant has shared a resource on best practices for developing effective pediatric patient partnerships. It's from the Patient-Centered Primary Care Coordination, if I'm not wrong. The link is from the AAPNJ website, and I'll make sure to share this link with everyone.
Perfect. Thank you.
Okay. Question is, can you provide me the reference for the post-DC follow-up phone call?
Sure. Yeah, that's actually, there's actually more data, and Dave Kuperberg, I know it's under, it's like in press with Pediatrics, so it should be out probably in the next month or two. It was also presented at the Pediatric Academic Society's meeting, so I could absolutely get you the reference for the abstract and then the article when it comes out, but I can certainly get you at least the abstract because it's really powerful stuff, so sure.
Okay. And do you know any professional college programs in order to be certified as a parent partner or parent coordinator?
I'm sorry, can you repeat that? A professional?
Yeah, do you know any professional college programs in order to be certified as a parent partner or parent coordinator?
So professional programs. So that's a great question. So there's great family-centered care training. So the Institute for Patient and Family-Centered Care has some great resources and training. Also, Family Voices also has parent leadership resources. I know locally also, for example, here in Pennsylvania, Liz Healy, who runs our Peel Center, which is our state Family Health Information Center, she runs a Parent Leadership Institute, which is like a series of webinars. So I would say, to whoever asked that question, the first place I would start would be your HRSA-funded Family Health Information Center. And if you don't know who that is, go to the Family Voices website, because Family Voices provides the technical assistance arm, and they oversee all of the F2S. And I would actually even encourage you to reach out to Family Voices and the Institute for Patient and Family-Centered Care, because if there's not something locally with where you reside, they can definitely help you locate some folks. Those are sort of like our national groups that tend to be kind of who I think of as a beacons, at least for me.
While we wait for additional comments and questions, I was hoping to know, Dr. Turchi, if there was any particular challenging experience in terms of communicating with patients regarding care coordination. If yes, how did you strategize dealing with that situation?
Yeah, that's a great question, Kunal. I think there's been a couple, excuse me, things that I feel like I've learned. And, you know, I feel like, you know, we always have to remember, and part of the trick to me that I feel like I've learned from my mentors is, you know, just always being open to when things aren't working well so you can get better. You know, my clinical practice is just primary care for children with special health care needs, which I love. And one of the things that I find sometimes really hard is getting families not great news. And I recently had a situation where we had twins who we knew upon their discharge from the NICU we're going to have some type of genetic syndrome, but they didn't have an official diagnosis upon discharge. And I had seen them, I guess, probably 2 times, and then I got a call from the geneticist one day with the diagnosis of Walker-Warburg syndrome, which is not a favorable prognosis at all, probably one of the worst things it could have been for them. And, you know, one of the things that I really have learned over time. And when I think back, and we had a large debrief after this particular meeting, and I said to my geneticist and my social worker, I thought to myself too that even 5 years ago, I don't know that it would have gone. It's hard to even say it goes well, because it's like the most devastating thing to be telling a family something that's not good about their child. But I think that's, optimizing that communication is so paramount. And one of the things that when I reflect on that, what made it better than some of those discussions have gone in the past, was that the geneticist talked to me. She clearly has had a lot of experience. She's a fairly new geneticist to my institution. She has a lot of experience giving this type of news. And she recommended that we set up a meeting all together, that it was just with her and me and someone else in my office who turned out to be my social worker that knew the family well. And in this case also the family, that English is not their first language, so we had an on-site interpreter, which again I think I've learned over time too. Having on-site interpreters they're more expensive, but anytime you have to deliver any type of difficult news or news that can be challenging, like a patient that, maybe has a new G-tube or there's a new teach, a new technology, having an on-site interpreter has made all the difference. It was a horrible meeting in the sense that obviously the family was devastated, but they felt supported. And I felt like, we also, I think one of the things I learned over time is that sometimes when you're delivering bad news in communication, we have to remember that families, just like many of us, you hear something not great, you often don't hear anything sort of after that. And recognizing that sometimes communication, we sometimes, I think in medicine, and I hold myself in this arena, we have knowledge and we're trained to diagnose and treat, so we almost like vomit on patients with all this information. And our hearts are often in the right place, but we have to recognize sometimes that things need to be talked about multiple times. And also that, thinking about when you are going to be having any type of situations where communication is particularly important, encouraging families to bring a support member with them that can be present, maybe getting child care for another child so they can be fully focused on your engagement. The only other thing that I'll say that I've learned too is to always be really cognizant of dynamics in families and who's in rooms, and having opportunities to screen for things like ACEs and domestic violence for some of our family members when they're alone. I think sometimes we have to remember that when we screen for pretty sensitive things, that we can be putting patients at risk, not knowingly. And those are just two things that come to mind in terms of communication and things that I feel like I learned perhaps the hard way.
That was insightful. One of the things that we learned from the cultural humility webinar was, one of the participants had encouraged or commented on including cultural beliefs of the patient population when working with them. So, and based on your presentation, I also recognized, perhaps it was somewhere known, but I realized the importance of communication through non-verbal means as well, electronic communication as well. So thank you for highlighting that today. If you have any questions, this is to the participants. Please feel free to type in the question box.
The other thing, Kunal, I might mention while we're waiting, if anybody else has a question, the thing to think about that I know was touched on in the cultural humility lecture webinar is to also think about literacy, right? Because a lot of what I talked about today really assumes that families have a functional level of literacy. So thinking about and knowing your population, in terms of their literacy, both, there's literacy in terms of reading, there's literacy in terms of limited English proficiency, there's also health literacy. Folks can sometimes read, but, the health world, and sometimes, we have our own language. So thinking about communication, if a family can't, Also, we've learned that with our patient portal, for example, many of our families don't have laptops, but most of our families have smartphones. So we learned that from just doing a quick survey with some students that the importance for us with our portal of having an app really is going to foster communication, because just having the portal and giving families a slip and saying, hey, log on. Well, if I don't have a laptop at home and I didn't realize there was an app to access it, how would I know? So I think it's so important to, understand your population well, and don't assume that, hey, just because I have, a large population of Spanish-speaking patients that if I translate everything, I'm accessible. As you know from the cultural humility webinar, that it's so beyond that. And, if you don't have cultural humility and competency, you're not going to be an effective communicator.
True. In the interest of time, we would like to thank everybody on this call today, especially Dr. Turchi, for giving this presentation. Just quick housekeeping items. All the handouts are accessible through your control panel, including the slides from today's presentation. And a quick reminder, should you be interested in claiming your CME credit, please complete your evaluation latest by tonight. This is the CME office requirement. Should you have any questions, feel free to contact us regarding the CME credit and or any items regarding this webinar series. This webinar, the recorded webinars, will be available at a later date for on-demand viewing, and CME credits will be offered for that as well. On that note, once again, thank you everyone for your time, and we look forward to continuing to collaborate, learn, and share with you. Thanks very much.